everyone, and thank you for joining today's webinar. I'm Megan Lott, Deputy Director of Healthy Eating Research, and I want to welcome you to our webinar on Latinos Rising, building a cohesive culture for health equity in the United States. Healthy Eating Research is a national program of the Robert Wood Johnson Foundation. The program supports research on policy, systems, and environmental change strategies with strong potential to promote the health and well-being of children and that advance health equity in the areas of diet quality, nutritional disparities, food security, and childhood obesity. We are very excited to present this webinar today. It's the second in a series of equity and research-focused webinars we are offering this year. It's based on a recent report on Latino health and discrimination by Dr. Amelie Ramirez of Salud America, who will be presenting on this webinar. We are very grateful to the speakers and thrilled to be able to offer this important content as a webinar. Before we get started, I want to go over a couple of logistics with you all. If you experience technical difficulties joining the session or viewing the presentation, please let us know in the chat. Audio for the webinar will be streamed to your computer speakers. During today's presentation, all of our participants will be in a listen-only mode. The webinar is being recorded and will be available on HER's website within a few days. We will send a follow-up email when the materials are available online. To submit a question at any point during the webinar, please use the Q&A box function. We encourage you to submit your questions at any time during the presentation. Audience questions, however, will be held until the presentations have finished. The content will last about an hour in total, with 10 minutes at the end for Q&A. Now I'm going to introduce our moderator and first presenter, Dr. Amelie Ramirez. Dr. Ramirez is an internationally recognized researcher in Latino health promotion and behavioral change and director of Salud America and its home base, the Institute for Health Promotion Research at UT Health San Antonio. Dr. Ramirez has spent 30 years directing research on human and organizational communication to reduce chronic disease and cancer health disparities affecting Latinos, including cancer risk factors, clinical trial recruitment, tobacco prevention, obesity prevention, healthy lifestyle promotion, and more. Please join me in welcoming Dr. Amelie Ramirez.
Good morning, Megan. How are you doing? And thank you so much for Healthy Eating Research inviting us to be part of this webinar. My colleagues, Cliff Dupre and Rosalie Aguilar, are also going to be joining us, and I'll introduce them in just a moment. So thank you so much. I'd like to share with you our program that we have developed called Salud America. It's been funded by the Robert Wood Johnson Foundation. This program has been going on for 10 years, and we've changed our focus over the years. We initially started focusing on childhood obesity, but then also realized that it really requires policy change to improve health for all. So Salud America is our program that now is focusing predominantly on health equity. Today, we'll briefly describe with you the diversity of our Latino population, what are some of the issues that they face with regards to discrimination, and also the need to really move forward in our development of more cohesion across our communities, and then talk a little bit about our future directions. And I think I can advance the slides here. Let's see.
You should be able to use the down arrow on the left. If you're having trouble, let me know, and I'm happy to take the control of the presentation back.
Great. Thank you very much. Oh, for some reason doesn't want to move me. So Megan, do you mind? was working earlier.
Sure, I will take control back. Please go ahead and I will resolve that.
If you can go to the next slide.
Amelie, I'm sorry. I think you have to pass the presenter privilege back to me.
Okay. Great. Thank you so much. So Salud America is really focused on, and our mission is to inspire people and to drive community change for the health of Latinos, but really for all families. And we do this through utilizing a very innovative digital content curation and multimedia communications with a special focus on health equity and advocacy. This gives us the flexibility to deal with a number of different topics from healthcare, education, trauma, housing, transit, green spaces, and many more issues. As I mentioned earlier, our funder is the Robert Wood Johnson Foundation, but we are housed at the UT Health Science Center in San Antonio. And on the next slide, Salud has really put together a unique aspect of focused on our social learning theories in terms of we go out and look for individuals who have made some positive changes with regards to health policy, and we share their stories through our digital network. Right now, we have over 400,000 individuals that are part of our network. This includes advocates, parents, teachers, individuals involved in policy, and just a number of different areas. And they work together with us to inspire that healthy community change. As you see here on the map, each of these bubbled areas is where many of our individuals and network members come from. The larger the bubble, the larger the representation that we have from these communities. As you can see, from a large portion come from the Southwest area, but also in the Northeast areas as well. And on the next slide, is it, we know, so that's just briefly Salud America, and I'd like to just kind of share with you a little bit more about the Latino populations. Many of you may have had questions about this. Well, Hispanics or Latinos, whichever term you prefer to use, is really a mosaic of cultures. This means that our population is truly a blend of racial and ethnic groups with ancestors from Spain, the Americas, and in some cases from Africa, giving our Hispanic population a history that predates that of the United States and a history that was set in motion by Spain's arrival to the New World. As you can see here on this map, the first European settlements in what was now the United States were Spanish. In fact, San Juan, Puerto Rico is the oldest city in with the United States flag. And this settlement dates back to 1521. Spain laid claim to a large section of North America, including Mexico and parts of our present-day United States, such as Florida, Louisiana, and our southwestern states. While the most extensive colonization occurred in Mexico, we have settlements that could be found in all of these areas. On the next slide, you'll see here that the census data on collecting information about race and ethnicity started back in the 30s, but I can tell you when I was in grade school, and I won't share what year that was, all the data was available in white, black, or other. And I remember coming home and asking my parents, well, where are we? Why isn't there a brown category? When you're in elementary school, you focus on colors. But what we've seen here is really a transition of finally acknowledging that Latinos are another ethnic group to be recognized. In the early 1900s, this population was really focused more on where they came from. So we were called Mexicans in Texas or Cubans in Florida. And so then, there was that little blip of color or race was the way individuals were designated. But then in the 60s, the civil rights movements began, and Latino leaders figured out that perhaps a broader category, umbrella category, or label was needed so that we could face more, deal with more of our national issues and get more federal attention. And it worked. And then eventually in the 70s, in 1976, Congress passed a law mandating the collection of information about U.S. residents of Mexican, Puerto Rican, Cuban, and Central and South American descent. But there still was just this broad category of Hispanic. The next slide. Then in the 1990s, there began to even be more interest in resistance against Hispanic, that it was largely due to the original strong connection with Spain and Spanish influence on our society. And this was truly more of a government term that was established. As we began doing my early research at that time, what we found is really the East and West Coast were using and embracing the term Latino, but in the central U.S., Hispanic was most commonly used. So again, when we began to embrace the term Latino, which some think is more accurately conveys unity within our shared history of European colonization and a common struggle for national independence. So Latino and Hispanics began being used interchangeably in the 2000 census. And on the next slide, most of you have probably been hearing the term Latinx. Well, this really emerged in the early 2000s as an alternative to Hispanic and Latino. But our linguists who are, really understand the Spanish language really have a hard time with that, because they're saying Latinos, when you refer to Latinos, that's a gender neutral term. But right now, 4 in 10 people describe Latinx as a gender neutral term, and that it's one that they feel is more inclusive. But others still use Latino and Hispanics and may prefer these terms due to the Spanish language-based division of gender. And we also see a difference in age groups as well, where the older Latinos or Hispanics prefer to use Latinos versus Latinx. On the next slide, Salud uses the term Latino. In the end, there is no one label and no one is right or wrong. Whatever you decide to describe our populations, there are a few things to keep in mind. First, you should recognize that they have their own preferences, like I just said, by age, by region. And in 2015, prior to Latinx, about half of Latinos preferred Latinos and about half preferred Hispanic. So now, in 2019, about 76% of our Latinos have never heard of Latinx, and Latinx is still very much an emerging term. Where we see it used most often is really in the media, because I think it makes it a little bit easier for them to utilize. And on the next slide, I just wanted to share with you the growth of our population. Again, when I initially started some of my research in the 90s, we in the Houston area in San Antonio were only represented about 6% of the U.S. population. And now, as you can see by this bar graph, how much the Hispanic population has grown. In fact, the Latinos are already the minority majority, and Hispanics have accounted for more than half of the total U.S. population growth since 2010. But again, many folks do not recognize that we are the majority minority. As of 2020, we represent 18.5% of the total U.S. population, and by 2060, the population growth are expected to reach 28%. And on the next slide, you'll see that Latinos are really everywhere in terms of geography. Before, we used to be primarily concentrated in the Southwest, but as you can see in this slide, it has seen a tremendous amount of growth. You'll see the growth in virtually every state and evidence that the growth is moving northward as well. On the next slide is a pie chart that kind of describes our diversity. Mexican Americans make up the primary population group here in the United States with and we're only second to Mexico. We represent almost 62% are Mexican Americans, then followed by Puerto Ricans at almost close to 10%, and then Cuban population about 4%. But as you'll see, the various regional categories here, there's another 15 that are not represented on this slide that represent a little less than 2% of other Latino populations. But again, you can see just the diversity of our population, and that's why we say our community really genetics is becoming more important for our community because of that. We run the range from European to Central African American, genetics in our population. So getting to know and understand that diversity is extremely important. On the next slide, at one time, there was raising why we as Latinos or Hispanics had a lower incidence of many health issues, and it was called the Latino or Hispanic paradox. However, things are beginning to change. We are now having some of the highest rates of obesity, higher rates of diabetes. Cancer is now the leading cause of death in Latinos, when for others it's cardiovascular disease. Alzheimer is also having a major impact on our population, and as we all know, COVID-19 has also had a tremendous impact on our community. And it's what we're finding is that our community is having these issues at an earlier age and therefore are living longer with the problem, because we live longer. We're not necessarily dying at a younger age, but are living longer, but our quality of life has been compromised because these illnesses and health problems are starting at an earlier age. On the next slide, you'll note that we have a number of inequities that have actually contributed to these health problems. For example, we have higher rates of poverty, less likely to have access to health care, less likely to have our children enrolled in early education, and then other issues such as unstable housing, unsafe transit. We have a great report, Salud America, on issues of transportation and how the redlining of districts impacted our communities. We have fewer safe places to play in parks and recreational areas, as well as food deserts in our communities. And then our communities also have more exposure to different types of environmental issues and toxins, and then a greater level of discrimination. So that's just a brief overview of who we are and some of the issues that are impacting our community. I now would like to transfer my presentation to Cliff Dupre, who's our Communications Director for Salud America, and has just really led us in terms of the diversity and the utilization of new communications tools to really enhance Salud America. So Cliff, thank you very much.
Yes, thank you, Dr. Ramirez. I appreciate that introduction. Well, for the next slide, we noticed how much Latinos and other people of color are suffering, just as Dr. Ramirez was mentioning. So we did a research review to kind of dig at the state of health equity, the reasons for some of those social and health inequities, and then try to find some potential solutions. So we found that, not surprisingly, that a widening socioeconomic gap and racism and discrimination were contributing to the inequitable distribution of health care and mental and physical health disparities among Latinos and other people of color, and those in poverty, especially amid COVID-19. And on the next slide, the research shows that discrimination really impacts educational attainment, starting at the earliest ages. So our children of color are often treated differently by school personnel. They're more likely to be harshly punished for leaving something minor, and teachers may underestimate their abilities. And the high school dropout rate among Latino students is much higher than white students, and even it's higher than black students as well. And this educational attainment gap is then linked to an increased risk of institutionalization, poor physical and mental health, and reduced lifetime earning and economic potential. And on the next slide, discrimination can also hinder people of color in other ways. We find that most people of color say that they've experienced discrimination or unfair treatment due to their race or ethnicity from either time to time or regularly, and that's including over half of Blacks, Latinos, and Asians. And more Americans say that being Latino hurts people's ability to get ahead in this country. And more Latinos than whites say they've been treated unfairly in the hiring, pay, or promotion processes. On the next slide, but it doesn't really have to be this way. So a cohesive culture for health equity is one where everyone works individually and as a group to help each person have a fair and just opportunity for health and wealth, as well as equitable access to basic resources that are required for these goals. And so our research review kind of really dove into how we can achieve a more cohesive culture like this. So on the next slide, and to head in that right direction, the research showed that we really got to help people understand and overcome the three big mechanisms that they use to discriminate against people of color and or to justify poverty. So covered in our research are implicit bias, system justification, and moral disengagement. On the next slide, we'll dive right into the first mechanism, which is implicit bias. As you probably know, bias is the tendency to favor one group over another. Many people, they think they don't have any bias toward other people, or they believe they know their biases and won't act on them, but everyone really truly has implicit bias because it's those preconceived notions or stereotypes that affect our understanding and decisions about others, and they operate largely beyond our conscious control. So as our brains use a shortcut to categorize everything that we encounter, like perceptions about people are based on income, race, ethnicity, education, their style of dress, and all of that leads us to behave a certain way toward those people involuntarily. So on the next slide, and that can manifest in a number of different ways in different realms of society. A series of studies that we didn't research, but we found in our research review, found that primary care physicians that are more likely to be white expressed very weak levels of explicit bias toward Black and Latino patients. But the research found that most of these physicians had implicit bias against Black and Latino patients, that 2/3 of physicians showed implicit bias that favored whites and had negative views of people of color. So that's a problem. The next mechanism is system justification. And this theorizes that people will rationalize whatever the status quo is, that they will believe that the social, economic, and political systems must be fair and advantageous for everyone, or they wouldn't be in place. So in other words, there's a general subjective motive that's justifying those existing socioeconomic order of poverty and the rich and the poor. And that motive that is largely implicit is partially responsible for creating and maintaining the inferiority of people of color and those in poverty. And system justification is potentially a strong motivator of human behavior because it addresses like the fundamental human need to reduce threat levels and reduce uncertainty and reduce social discord. And system justification can make people feel better about the status quo and what's happening on an emotional level, but at the same time, that will also hinder efforts for health equity, such as racial justice, reducing that rich-poor gap, or curbing Latino health inequities. And the final mechanism that people use to excuse poverty and discrimination is moral disengagement, and it's the cognitive process of decoupling one's internal moral standards from one's actions, and this allows oneself to conduct unethical behavior without feeling guilt or distress from doing that behavior. And so we found that there's mainly four types of moral disengagement. The first is moral justification, and that's where the immoral action is seen as serving the greater good, so that it kind of excuses the behavior for the greater good. The second is diffusing responsibility, and that's the immoral action comes from an order from an authority figure, so they don't really have to be responsible for their decisions, they believe. And the third is minimizing injurious consequences, in which the person tells him or herself that the outcome of their behavior or action will not be a big deal. And then the fourth way that people use moral disengagement is to dehumanize the victim, and that the person who's doing the behavior kind of reduces identification with the victim and they kind of say that the victim made themselves a target for the action. Anyway, we see that a lot going on these days. On the next slide, Latinos and other outgroups suffer consequences of these biases and racism and discrimination that result in negative interactions with those acting with moral disengagement. So they experience people acting with moral disengagement in those various ways with doctors, police, during the hiring process, or at the workplace in various ways. And unfortunately, like I mentioned before, it doesn't have to be this way, and we intentionally did our research review in a way that would kind of identify some of these things, and then we'll try to dive into solutions. So I'm going to pass to my colleague, Rosalie Aguilar, now to show how we can start to overcome some of these mechanisms. Rosalie has been our program coordinator for the past 8 years and recently achieved a great milestone in defending her doctoral thesis in translational science. So she's got a lot to say on how we can address some of these things. So Rosalie.
Hi, good afternoon. Thank you so much, Cliff and Dr. Ramirez. So if we can move on to the next slide, just to kind of follow up or continuing off of what Cliff just discussed, in our research review, we focused a bit more on how we can also overcome those mechanisms and achieve social cohesion as our goal. So social cohesion represents the capacity of a society to ensure the long-term physical and psychological well-being of its members. And a cohesive society in general is one that is inclusive. It's one that is without significant disparities in health, wealth, and income. And it's one that values other individuals' backgrounds. So it's integrating those from different backgrounds in such a way that everyone can relate to one another. However, unfortunately, what we found in our research review is that social cohesion has been on the decline in the U.S., and this is mainly due to deprivation and inequality that's experienced by those particularly living in poverty. So next slide. Fortunately, an increase in social cohesion can actually create feelings of solidarity. So that's kind of our goal, and our aim is that this manifests as eagerness to help others on an individual level and enhance social support systems on an institutional level, because that's also very important. Social interaction with others does affect our health outcomes, as you can imagine, and as relationships can facilitate the sharing of resources and help increase opportunities and improve livelihood. So in our work, we found that intergroup contact, peer modeling, awareness-provoking interventions, and use of targeted social media can improve social cohesion and compassion towards minority and impoverished out groups. And these tend to be the minority groups, right? So these actions can also counteract stereotypes and reduce health disparities and inequities. So, you know, on the previous slide, as you saw, there are 5 main ways that we are looking to go about, that the research demonstrates ways for actually achieving social cohesion. And these are intergroup contact theory, peer modeling, implicit bias training, effective communication, and then, of course, social media for change, which we know can be used for good as well as not so good all the time. But we do, and we will provide an example to show you how this is done. So on the next slide, first I'll start off explaining intergroup contact theory. We know that members of one group having incomplete or inaccurate ideas about members of another group can often, this is a way that we can positively change their beliefs and attitudes towards that group via contact. So it's very important that there be either face-to-face or interactive or even on digital media. Many even from younger generation now are finding ways to connect and relate to others, whether that be face-to-face or on digital platforms. And so this contact we're finding is very important. On the next slide, kind of continuing off of that with examples, we found that in our research review, one study found that more of this interpersonal contact with Latino immigrants actually predicted fewer calls and fewer calls for lowering immigration rates, or fewer calls for increasing border security, and also fewer calls leading to things like workplace raids. In another study in our research review, we saw that 77% of white, 14% of Black, and 9% of Latino adults. Researchers found that in these groups, there were lower levels of anti-immigrant sentiment among Blacks, Latinos, and those with higher levels of education, of course, and also liberal political ideology, or those having immigrant friends. On the opposite end, conversely, we found that those with a religious affiliation tended to have higher levels of anti-immigrant sentiment. So that's perhaps an area where we do need to also be working more with some of these groups, and then kind of finding ways to promote more social cohesion. And so the next slide, which focuses on peer modeling. So peer modeling is what this does is, of course, similarly, it promotes positive intergroup attitudes through the knowledge that an in-group member has a close relationship with an out-group member. So these are stories that we can highlight, stories that we can share. The in-group friendship partner becomes a positive peer model and demonstrating tolerance in interacting with the out-group. So the out-group friendship partner becomes a positive example that repudiates the negative belief of the out-group. So it's important to highlight people, you know, as peer role models, and a lot of folks and community organizations, institutional level, everywhere. You know, we can highlight these individuals, what's happening at local faith-based institutions. This is another way to counteract this and promote cohesion. So on the next slide, we had similar interventions happening in schools. We saw in one of the studies that we reviewed that there were, among U.S. ninth graders, peer modeling was actually used through authentic stories of change behavior to overcome prejudice and promote positive intergroup interactions, and then reject moral disengagement processes, which came from the audience itself. And so in this study, we saw that a significant reduction in verbal aggression was noted in the school that had the program. And with those students who previously were reporting 5 or more experiences of verbal aggression, this decreased from 16% at baseline to 7% at follow-up in the school who had the program. In Salud America, again, we use peer modeling by writing stories and shooting mini documentaries of Salud heroes who are real people who've enacted a system or policy change or engaged in the behavior, the positive behaviors we're looking and hoping to see and promote as a culture across our country. And so we describe each step in our videos, in our stories of this process, everything starting from learning about the issue to the ideation of change and to implementation and sustainability and equity as well. So, these are all things that we try to highlight. We're very intentional about this on our website, where we share these stories on a very frequent basis. We're putting out new stories to promote cohesion. So on the next slide, please. So again, Cliff spoke a little bit about implicit bias, and many institutions are now focusing on implicit bias training programs. And these aim to improve intergroup contacts and attitudes and relations by actually rewiring our subconscious associations. And this is something that research shows we can actually do. So these kinds of trainings and those that use implicit association tests, the IAT, maybe perhaps several of you are familiar with the IAT, which actually measures the strength with which race, ethnicity are associated with attributes such as a good or bad attribute. And these can be useful tools for organizations working on training programs or wanting to kind of help their employees or staff understand and address issues of individual unconscious bias. So it's important that we also institutionally work to offer these type of trainings to our folks at our institutions. And so, for instance, on the next slide, we highlight as one of our heroes Dr. Gibran Pasha, who has done some wonderful work. He's for healthcare workers in particular, where we know there's also lots of published research on this, the impact that healthcare workers' implicit bias can actually have on patient treatment decisions and outcomes. And so what Dr. Pasha has done is he's created a workshop, and it's called Unlocking Implicit Bias, which aims to be straightforward, compassionate, and empathetic. And the workshop incorporates different poignant storytelling, events, and trends from national headlines, and Dr. Pasha's own personal anecdotes featuring his experience as both the perpetrator and the victim of implicit bias. So removing feelings of shame and guilt that many people associate with implicit bias. And so it's importantly, participants are able to then work together to formulate a personalized list of methods to be able to combat our own implicit biases. So that's a nice story that we've been able to highlight, and others can also model. We have plans to hopefully later on roll out some materials, some action packs and tools to help others implement something similar in their own organizations. And so another group that offers a lot of great insight and tips is the Kirwan Institute. They've put out several training tools, and we've also interviewed folks from there who, as our heroes, who've made kind of the first set of publicly available online training models. And these are offered available for free, tailored specifically towards K through 12 educators. So it's important that these tools are available at all levels, starting from the earliest of years all the way through into the workforce. So on the next slide, again, effective communication. Effective communication allows individuals to voice their points of views without attacking another's views and without feeling attacked. So it sounds impossible, right? But, well, at least on Twitter. But if we go on to the next slide, there are some ways that we can work to promote this effective communication and facilitate these conversations. So, you know, it's possible that in person that we can do this as long as we kind of lay some ground rules in advance. Some examples might be kind of setting the ground rules and structures for speaking, listening to others, allowing for equal participation, sharing core beliefs, exploring different doubts and uncertainties, asking genuine questions of others, and then avoiding, of course, inflammatory language, which is a must. And the goal of the project is not for parties to really reach an agreement at the end, but rather to listen and understand one another. So these are, you know, again, practices that we could be implementing at all levels. The next slide, please, is social media change, as I mentioned before. Even where there's a lot of misinformation, unfortunately, on social media, social change can still arise from digital platforms. And I'll get right to the next example on the following slide, which many of you, I'm sure, are aware of the Black Lives Matter movement. And actually, perhaps some may not be aware, but the movement actually began several years ago and started off of a tweet and a hashtag that was used. It was after the acquittal of George Zimmerman for the shooting of Trayvon Martin. And so it's since reached and engaged millions of people across the U.S. and across the globe, becoming an organization with different chapters in more than 30 cities. So the death of Martin and the subsequent deaths of others such as Michael Brown, Freddie Gray, Sandra Bland, Breonna Taylor, George Floyd, and several others at the hands of police illustrated that different traumatic events often lead to social sharing and to seeking of support. In this case, leading to the growth of a movement that strives to end systemic racial inequality against Blacks and people of color. So we're having this conversation now that perhaps hadn't before been possible on social media. So next slide, please. So at this point, I am going to hand things back to Dr. Ramirez now for our new and future directions and then for some questions.
Great. Thank you so much, Rosalie, for that eloquent presentation on the importance of cohesion and moving towards cohesion, because our country certainly needs that right now. So thank you very much. I'd like to focus a little bit on kind of our new and future directions for Salud America and share again also some additional tools that the team has prepared. The first, and building off of where Rosalie just left off in terms of the hashtag Black Lives Matter movement and things that we saw with George Floyd and a number of other issues that have come up over the last 9 months and before, as Rosalie indicated, we really felt that it was important to say that our country needed to take a more public action towards declaring racism as a public health issue, and to make a real commitment to action. So we've designed these toolkits that Salud America makes available through its networks of, again, guidance on how people can make change at their local level. And this is just one example where we identified 3 different steps that communities could take to start asking their communities, what can we do to declare racism as an issue in our public health systems, and how can we improve? And San Antonio is actually one of 130 municipalities and states that have already made these resolutions, and we hope to keep these resolutions going into over the next few months, and then shifting gears in terms of generating important social justice and changes that we see are also necessary. All of these tools that I'm going to share with you are available on our website, so we encourage you to visit our website. On the next slide, another tool for change is we know that a lot of our children are experiencing a lot of distress. Some of them may even be experiencing some domestic violence, or been hurt, or seen some incidents in their own household and need support. These children still need to go on to class and carry on, either over this past summer or as we go into another break with the pandemic. So how can we best help them? So we created an action pack to work with the police, school, and mental health care leaders to start a program called Handle with Care. And so through this program, the police notify schools when they encounter children who have experienced a traumatic scene, so that the schools can provide some support right away. And they can virtually support kids, especially now through COVID. But it's a way of, again, how to connect different resources in your community to help others that might be in need. On the next slide, we also developed something that's called the Health Equity Report Card that is based on local data. And you can go to this report by just, entering salud.to/equity report and go in there and enter your county. And once you enter your county, you will be able to produce a report that will give you information regarding poverty, housing, transit, healthcare issues that are impacting your community. So, and this is a nice report that either you can share with some of your city council members, or if you're trying to target a school and helping improve the foods in the school, that you can take to the PTAs. It's a nice condensed report that the team has organized. And then also, if you need some help, we can provide a little bit of technical assistance. But in our tools are examples of what can be done, messaging that you can use to help you tailor your specific message to your community. And then on the next slide, Salud America has just really, over the last 9 months, had a strong focus on how COVID-19 has impacted the Latino community. And we saw a number of issues that needed to be addressed, or how could we help our communities maintain their income or get additional income? How could we reduce poverty? And so we identified other areas that were being impacted by COVID as well, that we needed to see our SNAP benefits increase to our community, that our community needed affordable housing, we needed to support disadvantaged families and immigrant families, and mainly to continue maintaining a focus on education, because as you well know, many of our underrepresented communities didn't have the technology, right, to be able to access their lessons at home, didn't have computers, and so COVID really made us go into this immediate mode of how could we provide solutions for our many different areas. On the next slide, in addition, it was like COVID-19 also made us look at different working conditions. What we found is as people were getting ill, they just didn't have the health coverage. They couldn't take time off. Many of our Latino workers and who are essential workers work 2 jobs to try to maintain a decent level of support. And so when they work in those 2 jobs, the employers give them just enough hours where they're under 20 hours and don't have access to health care coverage. So again, we need to find better ways to help protect our workers who are struggling, and we need to work together to help increase paid leave in these policies for many of our individuals that have been impacted. And then on the next slide, here, we want to ensure health equity is a component of recovery. What we mean by this is that we don't want, now that the vaccine is out and a year from now, hopefully that most people have been vaccinated, that people forget what trauma COVID-19 occurred in many of our underrepresented and communities of color. It really uncovered a lot of issues that everybody wanted to ignore. But we now need to make sure that in our communities we have task forces that not only focus on COVID, but really looking at health equity. What kind of infrastructure changes do we need to make so that we can help all members of our community? How can we make sure that we have an equitable way of distributing the vaccine now that it's here? How can we truly encourage more civic engagement across our community? And how can we lend our voices for action and for change? That we have seen more social unrest now than we have in a long time. So many of our civil workers who were advocating for change back in the 60s, and felt that we, created some changes, but we're seeing that some of those changes are being eroded, and we need to work together to really promote that. We need to encourage individuals that are helping do planning in their communities or working on transit issues to make sure that they have leaders who can help them unlock the issues of health equity. On the next slide, as I mentioned, again, we have to have a more equitable response to COVID-19. We've seen it in our leaders that they're calling the virus the China virus. It's not the virus. The virus is the enemy, not the people. And so we really need to change the way we look at that situation. So we have to change our fundamental structures to help reduce, this influence of the politics on scientific decision making. We need to make sure that science leads. Science has really taken a huge hit this past year, and now we need to rebuild that trust in our community because there's so much misinformation out there regarding these biases. Oops, something's happening. If we can go back to the academic bias slide here, what we're also recently we're moving into the need to look at some of the biases that are in our own institutions. Many of our institutions obviously are based on donors that have had historical connections with even slavery in some instances, and some of the statues in some of our universities of people who were admired, had these ties, and we need to recognize that. And our new leaders in academic institutions need to stand up more. They need to realize that we need to provide more equitable opportunities. We find that individuals of color are less likely to get stipends and resources compared to white students. We find that standardized tests such as the GREs were utilized to keep women and people of color out of certain universities. We are now looking at our own institutions at the NIH level and who do they fund, and the funding disparities that we see there. Our historically Black colleges and universities and Hispanic serving institutions are consistently underfunded. And right now, the high cost of tuition, getting people into schools, going on to college, and the debt that they come out with, and the interest rate that they're being charged on these debts is just incredible. So again, we need to work together to make sure that we create a culture of inclusion and welcoming all students of color. On the next slide, we also see that the systemic biases that are going on, and so we need to make sure that we recruit more students of diverse backgrounds, that our faculty even represent diverse backgrounds. Even here, San Antonio being a Hispanic serving institution, our faculty numbers of Latinos are still underreported. A UT campus at Austin was just recently in the newspaper because, again, they found big disparities in pay between faculty of color versus white faculty. So we need to work together to look at, where are the resources? Where can we provide better support for within our academic institutions? And we need funding investments. We need to increase grant opportunities to research racism and race studies. We need to look at how we can establish better connections and investments in our schools that are serving our communities of color. We do a lot of work with our cancer center here, and now cancer centers are really saying, who are you serving? What are you doing with regards to community outreach and engagement? So there's finally that pressure and insistence to say that we should be addressing those issues that are most impacting our community and making sure that we're listening to our communities as well. On the next slide, again, I've mentioned the U.S. Latino population represents 18.5% of the population in the United States, but less than 10% participate in NCI clinical trials, and less than 4% participate in FDA trials. Many of our pharmaceuticals were going outside the United States to conduct their trials where they could convince people to participate in them, but then when those drugs were developed, they weren't necessarily representative of the makeup here in the United States. So clinical trials is becoming a very big issue, became a big issue in developing the vaccine for COVID-19, where even though there was a strong emphasis placed in some of the trials, only about 20% of the individuals that were participating were of communities or individuals of color. So if we want to make sure that that vaccine is applicable to all of us, we need to make sure that we are represented in those trials. So we are taking on a little bit more. We're working with Genentech to focus on making sure that we have more equity in our clinical trials. We're just going to be launching this program starting in January, but we know what some of the barriers are, lack of awareness about what a clinical trial is, distrust in the science, the things that historically have happened and how people have been treated, the concept that individuals are guinea pigs in clinical trials. So we're really trying to shift all of that and really focus more on the enablers, how important it is to trust your doctors, trust the trials that are centers that are conducting the trials, and giving more of a hope and the future for other individuals that may be impacted by this illness. making sure that we have that cultural information that's in a language that is understood by our community. And also embracing families when you need to discuss this. It's not just an individual decision, but it involves the family members as well. On the next slide, so we are working hard to diversify our trials, and so we're going to try to do and develop some new approaches that really start with the patient from underrepresented community groups, in our case, the special emphasis in working with Latinos. And, how can we provide this information that's very unique? It's until you're sick and need something for yourself that these trials become available. And I know we're running short on time, and so the next slide, just real quickly, we want to make sure that our interventions are culturally sensitive in reaching our populations and communicating with them and really addressing the barriers that keep them from participation. And the last two slides just really focus on, we need to focus on the pipeline and to really diversify our pipeline. Even though we represent 18% of the population, less than 6% of our Latinos go in to get a doctoral degree. So we're so excited for Rosalie. We need more individuals from our community to pursue these degrees. And we have a program on the last slide called Exito that we really encourage individuals at a master's level to go in for a doctoral degree, and we work very, very, very closely with them. We've had over 200 individuals participate in this program. 55 are currently enrolled in a doctoral program, and 14 have already graduated. So we're adding to that, increasing that number in that pool of Latinos who want to do more research. So thank you all very much, Megan and Mary and others. We appreciate it, and we've just got a few minutes for one or two questions, so thank you.
Thank you all so much for wonderful presentations. We do have a couple of questions in the queue. One in particular, Dr. Ramirez, going back to the beginning of the presentation, can you clarify the confusion caused by the issue of race versus ethnicity in data collection? So the fact that people of Hispanic origins are also asked to check a race, and most but not all check white. So data for whites might capture data for Hispanics unless this issue is addressed in the analysis.
That's correct, and many times people, when we're collecting data, particularly in clinical settings, it's somebody else who's actually checking that box for you. So we have to be very careful. A Latino with an English-sounding name, may be identified as white, which is fine because that's our race. Our race is white, but then our ethnicity is separate. And so those are two different issues that we, or not issues, but items that we have to address. And that's why once you identify your race and then go into kind of ethnicity questions. And then part of it is based on the color and where that person was raised primarily, for our more Afro-Central Latinos who feel like they identify more with the African American community versus the Latino community. So it's really important to ask the person how they feel and what, to identify that question.
That's very helpful advice. We also have a couple of questions about the health equity report card you shared. How current is the data in the county health equity report card? And then also, can you pull a report by state using that tool?
I'll let Cliff answer that.
Yes, thank you. Good question. It's updated on a daily basis. We are tapped into those databases, so they update automatically, and people can generate the latest information on their county level. What was the second half of the question?
Can you do it by state?
Yeah.
It compares your county to your state. So there's not necessarily a state one, but you can do county health rankings. They do a lot of state comparisons as well if you're interested in that. But the Salud report card will give you a lot of good information on the county and how it compares to the state and how it compares to the nation.
Great. And you talked a lot about what academic institutions can do to take bias into consideration. But really curious if there are any additional tips you have for addressing discrimination at the university level, or also, what specific steps can nonprofits take to ensure that health equity for Latinos is achieved?
That's a great question. We really need to work together, and take different steps, identify what's important for that nonprofit organization to want to deal with, just to look around and who have they hired, to help them with a number of the programs that they're developing. Are they being included